Hello and welcome to Kingsbridge HealthStyle, the health and wellbeing podcast from the Kingsbridge Healthcare Group. My name is Avril Keys, your host, and I will be putting real patient questions to our consultant specialists from across the group. From diagnostics through to treatment, we will give you the lowdown on what to look out for and when and how you should make an appointment. Thank you to everyone who has sent through their questions. If you do have a question or would like to find out more about any of our services, contact details will be listed within the information box below. So let's get started, and I hope you enjoy listening. Our guest today on the podcast is Professor Suneil Jain, and you can tell us what your specialty is and what your role is, if you would please, in Kingsbridge.
I'm a professor and consultant in clinical oncology.
Okay.
So what that means is that I treat men that are diagnosed with prostate cancer, and I treat patients either with advanced forms of radiotherapy treatment or with drug therapy such as hormone therapy or systemic therapy like chemotherapy.
Okay. So bringing it right back here, as a woman, I don't know anything about the prostate gland. Can you tell me, what it is, where it is, and what its function is in the body?
Sure, yes. So the prostate gland is a little small gland, normally about the size of a walnut. It sits right in the middle of a man's pelvis, very close to the bladder, very close to the rectum or the bowel. The urine tube runs right through the middle of the prostate gland, and the nerves that supply the erections lie just below the prostate gland.
Okay.
Its job is actually to produce fluid that mixes with sperm to become the semen. So it's a very important organ, but as men get older, it often slowly grows, and that benign enlargement can cause symptoms. But also with time, for some men, they can develop a cancer in the prostate gland as well, and that is the condition that I would treat as an oncologist.
Okay, and so within Kingsbridge, I'm aware that there's a sort of a prostate clinic that that can bring men through from say early symptoms right through to the point where they might see you. And so what's the process that happens there if you were to present? What's the I suppose the pathway through to coming to see you?
Yeah. So some men will have had their PSA checked with their GP.
And the PSA then is what?
PSA is a blood test. It's a protein that is excreted into the blood and can be measured. And it's a very useful test for us. It's not perfect, but if it's elevated, it may suggest that a man could have a prostate cancer. It can be elevated for other reasons, as I mentioned, the prostate just getting bigger as men get older, or if it was inflamed, or if there was an infection in the urine. But it could suggest that there's a prostate cancer that may need to be treated.
So that would be like the first step, is to have that blood test then?
So first step is generally getting a PSA blood test. So as I say, that can be carried out by the patient's GP or by a private GP in a centre such as the Kingsbridge Prostate Clinic. If men have symptoms like lower urinary tract symptoms, so they're going to the toilet more often, they're up at night, urinary flow isn't as good as it normally was, if they had blood in the urine, or if they had experienced erectile dysfunction, those are indications for testing a PSA in primary care.
Okay.
But men over 50 also have the right to request a PSA check. They should be aware of the pros and cons of having a PSA test done, but if they wanted to do that after they had educated themselves, then they would have the right to have a PSA check.
So even if they were symptomless?
Yeah, because most men with prostate cancer don't actually have symptoms. It's just slowly growing in the prostate gland without actually causing any problems or any symptoms for that man. So for that reason, patients have the right to request a PSA test. But as I say, they should be aware of the pros and cons of doing that. And obviously the pros are that a man might have their prostate cancer picked up at an earlier stage where it is more treatable and the treatment might be less intensive. And also regular PSA tests allow monitoring of the change of the PSA over time. But there are some potential downsides to PSA testing as well. in that it could lead to more investigations like an MRI scan or prostate biopsies, which could have side effects. The PSA may be elevated for other reasons, so the patient may not have a prostate cancer despite having those investigations.
Okay.
And for some men, they may be diagnosed with a very early prostate cancer that actually may not ever cause them any problems, so they may end up being diagnosed with a prostate cancer that perhaps they didn't need to be diagnosed with.
Okay.
So it's a balance, and it's an individual decision for each man as to whether they wish to have a PSA test.
And is it hereditary? Or are there certain markers in your life that would lead you to have one, maybe more than another person?
Yeah, so men who have a first degree relative, for instance, their father or their brother who had prostate cancer, are at increased risk, about 2.5 times more likely to be diagnosed with prostate cancer in their lifetime. So that is a factor whereby we feel that more consideration should be given to having a PSA test. Similarly, men of African American descent are at higher risk of developing prostate cancer for reasons we don't fully understand as yet. So there are some risk factors for prostate cancer.
Okay, and then there are obviously lots of different treatments. We were talking about them before we started recording the podcast, and I understand there's some treatments available in Kingsbridge that are pretty leading edge and wouldn't be available widely or on the NHS.
Yeah, so prostate cancer is the treatment, the diagnosis and the treatment are changing very, very quickly. It's a very exciting field of medicine to be involved in, and part of my role as a professor, about half my time is spent treating patients, but about half of my time is spent carrying out research into prostate cancer as well. So we are a UK prostate cancer centre of excellence here in Belfast, and we do work with a lot of different researchers and do lots of clinical studies looking at improving the way that we treat prostate cancer. So there have been some excellent improvements in how we treat prostate cancer in recent years. So for many men, they will have a choice of which treatment they wish to have. So we will spend some time discussing their options. They're also likely to meet one of our surgical colleagues if they're eligible for a surgical procedure as well. And then we work with the patient and their family to decide with them which treatment is best for them. But quite often there are extras that we can do to either improve the outcome of treatment or to reduce the side effects of treatment. So I suppose we talked about radiotherapy and drug therapy to some extent already. So if we think about radiotherapy, it can be either given from the outside, which is called external beam radiotherapy, where one of our very high-tech radiotherapy machines goes around and gives treatment. And until relatively recently, we would have treated a man with about 7.5 to 8 weeks of radiotherapy treatment. They would have come once a day, Monday to Friday, 5 days a week for nearly 8 weeks. So it was a lot of different trips. And then some big UK clinical trial data showed that 20 treatments, 5 days a week for 4 weeks, was as good as 8 weeks of treatment. So we were able to reduce the treatment time by 50%.
And then side effects, I'm guessing?
Side effects were very similar in both groups, and very, very good in both groups actually as well. But we were able to halve the number of treatments, but without worsening side effects. And importantly, the control rates, the cure rates, were at least as good with the 20 treatment. And so that's one of our standards now, is 20 treatments of external beam radiotherapy over 4 weeks. But I did my fellowship in the University of Toronto some years ago now, but one of my big interests is looking at stereotactic radiotherapy, which is a more advanced form of radiotherapy again. And in that treatment, we deliver 5 treatments of radiotherapy over a period of 2 weeks. So patients can have their full curative dose of radiotherapy in 2 weeks, just 5 trips to the radiotherapy department.
With a similar outcome?
With similar outcomes. And again, we've run lots of large studies around the UK and beyond looking at that. But with all of these treatments, there are potential side effects. And as I mentioned, the bowel lies very close to the prostate, just behind the prostate gland. So one thing that we can do is a small procedure, a little bit like a prostate biopsy, but normally a bit more straightforward, where we inject a small amount of a flexible gel between the prostate and the rectum or the bowel.
Yeah.
And that pushes the bowel away from the prostate, normally by about 1 centimetre, which doesn't sound like that much, but because our radiotherapy is so precisely delivered, 1 centimetre makes a huge difference, and we've shown that that reduces the radiotherapy dose to the bowel by about 70%. And in a big study that was run in the US, reduces the risk of long-term bowel side effects from the radiotherapy. So that's something that we've been very keen on, and it's called a SpaceOAR, a prostate spacer device, and something that we do use quite commonly for men undergoing radiotherapy treatment. And actually in the same procedure we can also put 3 little gold markers into the prostate gland, and that means each day when the patient comes for their radiotherapy treatment, we can line the gold markers up to make sure they're in exactly the same position, the prostate's in the same position. It makes the treatment more accurate and more precise. And the final thing is imaging. So there's been real advances in imaging the prostate as well, and we would like to be able to combine an MRI scan with a CT scan for patients when they go through radiotherapy. That's not possible for all patients, but the benefit of an MRI scan is it really clearly shows you the prostate. So if you combine the MRI images with the CT images, you get the best picture of where the prostate gland is in the pelvis, and again that helps with the radiotherapy delivery.
Okay. Wow, it's a very leading edge indeed. And does the spacer, does it just break down then over time?
Yeah, it's a great question. So about 6 months' time, it hydrolyzes, it breaks down into water, it gets absorbed in the body, and it just excreted through the urine.
Amazing. Yeah. I'm sure it can be applied to other parts of medicine as well. That same
there's
ideas.
Absolutely. There's a lot of interest in looking at different cancer sites to see if the same thing could be achieved, whereby you push an organ at risk away from the tumour to allow you to treat the tumour to a higher dose or to reduce the side effects of the treatment. Yeah.
And so with all of this leading edge treatment, what are the rates of recovery and survival, I guess, in the case of some men?
So the survival very much depends on the stage of prostate cancer that the man is diagnosed with. There's really a big spectrum of prostate cancers, and we've really recognised this through a lot of genetic studies, whereby some prostate cancers are very slow growing and non-aggressive, and patients by and large will do very well. And then others can be really quite aggressive, and some of those can spread to other parts of the body even by the time the patient is diagnosed with their prostate cancer. Around about 15% of prostate cancers in the UK are diagnosed at that stage. So we spend a lot of time looking at the PSA levels, looking at the MRI scans, looking at the prostate biopsies, to see what sort of prostate cancer a patient has, and then to decide, working with the patient, on the best treatment plan. And the good news is that for many men, the aim of treatment is cure, is to get rid of the prostate cancer altogether. And for many men, we do achieve that. For men with localized prostate cancer that's all contained within the prostate gland, probably in the region of 85% of men with good treatment are cured of their prostate cancer. So in that way, it's in some ways a good prostate cancer, a good cancer to treat, because patients often do very well.
And is that determined by how quickly they can come to you? I suppose it's all about the speed of being able to get that diagnosis initially.
Yeah, I think certainly for some prostate cancers that is the case. Certainly for some of the more aggressive ones that are growing quickly, the sooner patients get diagnosed and get through to treatment, the better. For other ones that are slow growing, that time may not be as important. But you also mentioned side effects as well. So it's not all just about getting rid of the prostate cancer, it's about getting rid of it, but giving a man a high quality of life for the rest of their lives, because many of our men will live for many, many years after their treatment. So we're also very interested in minimising the risk of side effects. And as I said, the prostate sits very close to the bladder, the bowel,
Yeah.
and the nerves that supply the erections. So all of those can be side effects, urinary side effects, bowel side effects, or side effects in regard to the erections. So, but there are things that can be done to minimise the risk of those. And most men after treatment will enjoy a good quality of life after they've had their treatment for prostate cancer.
And is it ever removed, the gland itself?
Absolutely. So for many men, again with localised prostate cancer, they will have a choice that may include robotic-assisted radical prostatectomy, which is surgical removal of the prostate gland, external beam radiotherapy, possibly with some hormonal therapy, brachytherapy, which is a procedure that we do where we put radioactive seeds directly into the prostate gland to treat with radiotherapy that way, or for some men, what we call active surveillance, where we simply watch very closely the PSA levels and the prostate itself, because they may not need treatment at diagnosis. But surgery is one of the main treatment options for prostate cancer. It's done by my urology colleagues. But quite often we would like patients to meet with the surgeons and with the oncologists so that we can talk about the different treatment options to help them make a decision that's the best decision for them, because it's quite an individual decision.
Yes, of course. Yeah. And you talk about hormone therapy, so I presume that's testosterone, is it, or are there other hormones?
Yeah, it's actually hormone therapy that's trying to either lower testosterone levels or block the effects of testosterone, because testosterone, which is the male hormone, can stimulate the growth of prostate cancer. So we don't use that for all patients, but for some patients we would offer that in conjunction with other therapies, because it can be very effective at shrinking back the prostate cancer.
Okay, it's interesting. I suppose as a woman, and I know there'll be many women listening, are there any things I should be watching out for in my very medically reluctant husband to say, do you not think you should get that checked out? So I know you mentioned them earlier in the podcast, but just would be good to remind us of the kinds of things we might observe indeed in a brother, father, or husband, partner. Yeah,
and I think you're right. A lot of men, probably myself included, but certainly a lot of my patients are very reluctant to look into their health unless they absolutely have no other choice. So and quite often we do hear from partners or family members that they're urging that the patient went to their GP and was ultimately diagnosed with prostate cancer. So I think the things that we mentioned before, so if there's been a change in urinary function, so a patient is going more often, quite often we hear about people who are on the golf course and they have to nip off into the bushes a lot more, and maybe they or their partners notice that there's been a change, or they're up at night a lot more, or their flow isn't as good, or they've got blood in their urine, or they've got new erectile dysfunction. Those sorts of symptoms could relate to prostate cancer. They may not, it may be completely unrelated to prostate cancer, but it is a prompt to see your GP, discuss it, and potentially have your PSA checked. And then, as I mentioned, there's also a discussion to be had about the PSA test, because I think a lot of men simply don't know that it exists. They don't know what it is, that this simple blood test can be taken, which may detect the prostate cancer earlier, and they don't know that they have the right to have a PSA test if they have done some reading and looked at the pros and cons and decided it's something that they want to have. That they
particularly with the family history as well, if it's
in that scenario.
Your mind. And I guess, you talk about men being medically reluctant. I would imagine they would be medically even more reluctant because of where it is and the thought of maybe what treatment would be required. So, can you reassure, any men listening that it's, how invasive is it, or how difficult might it be for someone who's not keen to go to the doctor in the first place?
Yeah, well, I think the first step is a blood test, the PSA test. If you have symptoms, or if you decide you want to have that done, so that's easy.
Yeah.
The next step, should the PSA be raised or higher than it should be for a man of their age, is referral to urology, and that is straightforward. And often, if the urologists feel that investigations are required, it's an image, a scan, an MRI scan. Yes. And again, that is a non-invasive procedure. It's simply a scan, and at that stage, some men don't need any further investigation. So a lot of men will have been reassured already. And it'll only be a small proportion of patients that would ultimately go for prostate biopsy, and of those that would be diagnosed with prostate cancer. But for the men that are not, they get the reassurance that they have been checked out, and
it's
nothing
not that
concerning.
big a deal actually going through the process.
I think that's right. And we treat many patients. We have over 1,100 men a year in Northern Ireland diagnosed with prostate cancer. So we see a large number of patients every year, and I think the fear of the investigations or of the treatment is often much worse than what is actually involved. And yes, I think we, with good education and time,
and obviously the leading edge stuff that's coming in now, and the treatment and also the recovery rates are so good.
I don't think it's I don't think any man wants to be diagnosed with a prostate cancer or wants to go through treatment. But if that happens to you, I think almost always a man's fears and what they have in their head before they come and meet us are worse than what ultimately happens to them. Because our outcomes have got so good, and we've really focused this discussion on the localized prostate cancer. But I mentioned that 10 to 15% of patients, unfortunately, will be diagnosed at the stage where their cancer has spread to other parts of their bodies. But even then, in the last 10 years, there's been enormous progress made in using different types of therapies to improve survival rates for men who have cancer that's spread to other parts of the body. So there's a lot more that we can do now than we would have been able to do in the past, and outcomes have got better and better. So even when we meet those sorts of patients, I think when they've heard that sort of news, they just think that's it, it's all over, and that's not the case. Almost always we have lots of different treatments that we can use to prolong life and quality of life, and often for many years to come.
Yeah, that's good to know. And just in terms of an age profile then, is it typically men in their 50s, or are you seeing younger than that?
So our average age is about 70 years old. Another risk factor for prostate cancer is increasing age, because prostates get bigger and there's more likely that there'll be some change that ultimately develops into a prostate cancer. So average age is 70, but there's a big range on that. So we will treat men up into their 90s, but similarly we have treated men as young as their 30s as well. Now that is not common, but we do see men in their 30s and 40s, but more commonly 50s, 60s, 70s.
Yeah. So just a good awareness of the symptoms then is important for all age groups.
Yes, absolutely.
So just to finish the podcast, I wanted to ask you, can you give any practical advice to the men listening today in terms of just generally looking after their health and helping to hopefully prevent something sinister happening later in life? Yeah,
so we would routinely use the opportunity of meeting these men to advise them on what we call secondary prevention, which is basically any lifestyle measures that can reduce the risk of them developing other disease, for instance, heart disease or diabetes. And actually, one of the side effects of hormone therapy can be that it can unmask diabetes, or patients can gain weight, which can put them at increased risk of heart problems. So the advice is the common sense advice. Men should be active. They should be doing some form of exercise on a regular basis, be it gardening or walking or cycling, running, whichever of those floats their boat. They should have a healthy diet. It doesn't mean that they can't enjoy food, but on a day-to-day basis, they should have a healthy diet, and they should try and minimize weight gain. And all of those things are important for leading a longer and healthier life. So nothing more startling than that. But we are running some very interesting studies in prostate cancer, because there is some evidence that exercise can actually have an actual direct anti-tumoral effect. Now that hasn't been definitively proven yet, but there are studies going on right around the world looking at the impact of exercise on prostate cancer outcomes. And I think that's a really exciting new research field as well.
That's fantastic. Yeah. Well, thank you so much for your time
Not at
today
all.
and your advice.
Yep.